the slide. There was an Economic Times right up in 2019 that India continues to be the neglected COPD capital world, Economic Times. And they say that COPD causes more deaths than AIDS, TB, malaria, diabetes, all put together. Another grave factor is that around 99.15% of people had never heard of word COPD when they did survey. COPD, which was considered as the smoker's disease until the last 10 years, has seen an increase in the cases of non-smoking COPD. This is a major concern for the developing country like India. It is reported at least 1/4 of the patients suffering from COPD had never smoked. A burden of obstructive lung disease study also reports of a high prevalence of COPD in non-smokers. Women are more affected by household air pollution, and they are the people who are in the majority of non-smoker COPDs. Next slide. In global mortality rates of COPD, if we look, 1990 it was 4th in the global rating. 2012 it has become 2nd, and 2016 in India and the Southeast Pacific region it has become the 2nd rank COPD in the mortality rate. It is seen that in India and Southeast Asia, including China, the mortality is rapidly increasing to become the 1st rank holder. However, there is still no sign of any national program to contain COPD. I am sorry to say. Well, I am not sure of these rates because in our country, only pulmonologists use a spirometer. Very few general physicians refer for spirometry to my department. In the semi-urban and rural areas, this is more pathetic. In this country, 2/3 of COPD are never diagnosed. I am sure that all of you know this and nothing could be done about this in the near future. Next. Rapidly developing COPD research. When you look at the COPD research, there has been rapid developments in drugs for COPD. The ultra-LABAs, in combination with ultra-LAMAs, has helped remove the inhaled steroids from the early stage COPDs, 2nd stage, 3rd stage, and all. A long-acting fluticasone furoate, once daily, is combined with ultra-LABA and ultra-LAMA for management of very severe COPD. And they say the fluticasone, it does not, long-acting fluticasone will not produce that much of pneumonia. Roflumilast, which was abandoned by many of us because of its GIT side effects, has now appeared again in a 4-drug approach for COPD and can be used effectively in all those having no side effects. IL-5 drug trials, mepolizumab, rituximab, and benralizumab in COPD with eosinophilic sputum is going on. Multiomics, a tool of precision medicine, when you cannot properly phenotype and endotype a COPD patient, is revolutionizing the field of precision medicine in COPD. The new knowledge about maximum supplements with protein and L-carnitine after exercise and branched-chain amino acids by whey proteins and small carbohydrate meals, milk, fish, meat, and eggs will do adequate benefits for the patients on rehab program. There is a criticism that our rehab program is not very successful because we do not advise we are not only now we are having the L-carnitine and all these new proteins available with us. Next slide. Progress towards the development of strategies to regenerate the adult lung by either in vivo and in vitro, targeting the endogenous stem cells or pluripotent stem cells derivatives is limited by our fundamental lack of understanding of the mechanisms controlling human lung development. The precise identity and function of human lung, stem cell, and progenital cell types, and the genetic and epigenetic control of human lung fate. This was a cry of physiologists 2 years back. Now, lot of things have changed with relentless research, and pretty soon the identification of lung progenital cell will be the bronchi and alveolar epithelial regeneration methods will be discovered, and that will give a boon to pulmonary physicians. I hope during the next 2 hours, most of this will be discussed, and the young pulmonologists will carry home sufficient information which they can develop at home. Thank you all for. Now I have to do the inauguration of the website. A website which was came, what is known as a website. Website which came only in 1990. When I was in Yale, the website was discussed because it was discovered in the UK. And 1993, when I was in Trivandrum Medical College, the websites were the global web was launched, and we have the www World Wide Web already with us, and HTTP, which was the method of procuring files from the World Wide Web, is already there for us. And we have no website so far, and we are also launching. Everybody is launching websites. I also launched a website for some time, but I could not get time to do that and stopped it, and I don't know what has happened to it. So many people, so many institutions, so many centers, all launch websites. The main thing is that it is one of the information technology tools where you communicate people with people for people. When you have a website of our own, we will be having better communication with everyone. Let us hope that website will be of great help to our TAPCCM. I have great pleasure in inaugurating the website for our TAPCCM.
Thank you, sir. Hello, sir. I will be just showing our website, just an overview of the website. Am I audible?
Yes.
Yes, you are.
Yes, you are audible.
Yeah. So I will just showing that's our website. So is this visible?
Yes.
So this is our website of TAPCCM, Trivandrum Association of Pulmonary and Critical Care Medicine. Actually, the whole idea of website, actually it came with a history of, earlier it was known as the ARP, Association of Respiratory Physicians, and later on the name got changed to TAPCCM. So the whole design of the website is conceived by Dr. Sanjeev Nair sir, and the history of ARP was all input was given by Dr. Ravindra Nair sir. So in the front, this is a home page where you can see the history of ARP as well as the other details of the our association. Then there is a second tab known as upcoming activities. Am I audible? Are you following? Yeah. So in the upcoming activities, if you log in, you can see what all things are going to happen with our association. So today we are having the World COPD Day. The program agenda, the speakers, all will be updated in the upcoming activities. Then for the PG, for the residents, we are going to start a radiology quiz. Actually, it's a radiology quiz for a case per month. So what happens is that we will just project a image, a radiology image, and a time period will be given. And all PGs, they can have a look at the image, and answer should be sent to a WhatsApp number which is given below before 28th November. And those answers which are appropriate, that is, answers should be appropriate. Those who are getting the correct answers, the first prize winner will be declared in the next TAPCCM meeting, and if it is a physical meeting, will be given a prize also. Then there is an academic corner where it's all, as Ravindra Nair sir was saying, It was earlier known as the PG Corner. So here you can get links to the latest Gold 2021 reports, the GINA report, and the Government of Kerala COVID guidelines. We are just updating now. So this is for the launching purpose. We have just updated a few of the documents which is important for the residents to go through. Then if you want to know about our association, there is a tab which contains association bylaws, members list will be there, then minutes of meetings as well as membership. If anyone wants to join our TAP CCM, there is a membership form. This can be downloaded from our site, and this after filling you can submit to the secretary or the treasurer. Then with any website, although it's an academic oriented website, we also have a recreation corner where you will be able to see photos of our previous meetings and our professors when they were young and all. You can see all of them. We have just uploaded a few of the photos only, so we can see our professors in their early times and all. And also you also can contribute as good photos. One of our member, Dr. Ashish sir, he has given certain photos which can be shared. You can also can give your photos which can be shared in this. These are some of the photos taken by him. And also there is a literary corner where you can put in your articles and all. So this site will also have link to the Pulmon Journal, and also this site will be also publishing what all things which you publish in another journal, they can be published in this site also. So this is just an overview of our TAP CCM website. I hope everyone should have a look at this site so that we can keep it going, so that this can be a academic fees to all the residents as well as the consultants. Thank you all.
Good, well done.
Thank you, sir.
So shall we go to the sessions? Dr. P.G. Nair.
Yes, sir.
Okay.
So we are beginning today the sessions. Today we are beginning the sessions. So many, all the top leading pulmonologists of Trivandrum and our special guest, Dr. Ravindran C. from Wayanad, Calicut. And today I would also like to say it is his birthday, and he was so happy to be invited so that he could share a special message for COPD today, his special subject and special message for all the people of all over Kerala. So Dr. Ravindran sir, please start the meeting and the panel discussion.
I have great happiness to invite one of my colleagues, Dr. M. Joshi, to tell us what is new in the COPD guidelines of 2020. Because every year, the COPD guidelines by Gold have some changes. Because it is dynamic. New functions, new drugs will come, new programs will come. So naturally, they have to change it. Even then, our opinion is that they are still not up to date. Okay, let us hear from Dr. Joshi.
Joshi sir, please share your screen.
Please project his slides.
Hello, Joshi sir. Am I audible? Yes, sir. Yes, sir. Now your screen is now being visible. Please open the slideshow, sir. Sir, please maximize the COPD Gold 2020 changes, that PowerPoint slide. Yes, sir. Just click on the maximize window, that red, the PowerPoint maximize, that window. Yes, sir. Yes, sir. Then now click on slideshow, sir. Yeah. Then from beginning. Top left. No, sir. Just below that. From beginning. Yeah, from current slide. Okay, sir. That will do. Yeah. Yes, sir. Click on that, sir. Yes, sir. Yeah. Now you are ready to go, sir. Sir, you are not audible, sir. Sir, you are not audible. We can see your slides, but you are not audible.
Also not visible.
Yeah. Joshi sir, we can see your slides, but you are not audible, sir. Sir, just in your Zoom, sir, in your Zoom window, just mute and unmute your mic once again. It might work. Not in this screen, sir. In your Zoom screen. There is another window. You have to exit the slideshow. Just press Escape on the keyboard. Sir, could you just put on the video? Yeah. So now just go to the Zoom screen, sir. Minimize this window and go to the Zoom screen. That is your Google. Besides this, yeah. Just mute and unmute your mic once again. Yeah. Just speak up, sir. Now your mic is muted, sir. Press again and just speak up. Hello? We can see your screen, sir, but you're not audible. Just check with your system audio. Yeah, speaker's volume. Yeah. Sir, just speak up. Yeah, now it's high, but we are not hearing you, sir. Sir, are you using any headphones? Hello, sir. I think sir is having difficulty in the audio part. Devin sir, can we move with the next presentation so I can call him up and ask him to do it again?
Go to Dr. Ravindran.
I'm ready. Shall I upload my screen?
Yes.
Yeah, Joshi sir has to stop screen sharing now.
He has to stop it.
Yes, sir.
I think somebody can help him to sort out. Probably his headphone may be at
Yeah.
fault.
Yeah, I will
I will
just
finish
call
my
him,
talk
sir.
by that time if
Yeah.
the screen is
Yes, sir.
cut.
Yeah.
Okay.
Joshi sir, could you please stop the screen sharing? I will call you and we'll just have a walkthrough thing, sir. Yes, sir. Thank you, sir, Joshi sir. Over to C. Ravindran, sir.
Is it visible now?
Yes,
Yes.
sir.
Okay. Respected Ravindran sir, Joshi sir, Dr. Ghosh, and all my friends at Trivandrum. Respected President, TABCCM, Dr. Preeti Nair, thank you very much for inviting me to this session. With the time allotted to me, I will just go through a brief overview of what we can do in COPD exacerbation due to bacterial infections. As you all know, the definition, it's not important, everybody will be knowing the definition of acute exacerbation. Again, I am reiterating, acute event in the natural course of the disease, which is characterized by a change in patient baseline, dyspnea, cough, and or sputum. So beyond the normal day-to-day variation, that is important because to say COPD exacerbation, the existing symptoms should increase beyond the day-to-day variation, which warrant a change in the regular medication. So that will make an exacerbation. And what are the etiologies of exacerbations? Overall, when we take exacerbations, respiratory tract infections become the first, which can be due to bacterial, viral, and fungal. And my topic today is bacterial infections. And other causes like exposure to irritants and pollutants, pneumothorax, pulmonary embolism, pleural effusion, right heart failure, all this will come, and about 20-25% of COPD exacerbations are due to this, but 75% of exacerbations are due to infections, and 50% of exacerbations are due to bacterial infections. Again, the same thing is given, infective and non-infective. Viral, we have respiratory syncytial virus, rhinovirus, influenza virus, and parainfluenza virus. And our topic of interest is bacterial. About 50% of COPD exacerbations are due to bacteria. And most important cause is Haemophilus influenza, followed by Streptococcus pneumonia. And other organisms are Moraxella and Mycoplasma. And we have difficult organisms like Pseudomonas aeruginosa, Acinetobacter, and coliforms. So other non-infective causes, as I already mentioned, these are the important non-infective causes. And most common infectious cause of COPD exacerbation is bacterial pneumonia, which is Haemophilus, Streptococcus, Moraxella, Mycoplasma, Chlamydia. Then severe exacerbation can be due to Pseudomonas, Acinetobacter, and other gram-negative enteric bacilli. What is the importance of COPD exacerbation? Why we give it so much of importance? And that is the impact of exacerbation which is created on a COPD patient. It increases the symptom. We know that even COPD patients are having day-to-day symptoms affecting their daily life. And these symptoms are worsened in exacerbation. The lung function is getting reduced due to an exacerbation. And once an exacerbation occurs, there is an acceleration in the decline of lung function in future life. And it deteriorates the quality of life of a patient, increase the economic cost of the patient for treatment and follow-up. And then it increases the mortality also. We know that we lose so many patients during exacerbation, especially in monsoon period, July, August season. We lose a lot of COPD patients when they come with bacterial infection and exacerbations. So that's the impact of exacerbation on a COPD patient. And diagnosis, when we have an exacerbation, there is no time for an elaborate investigation in this patient because most of them appear in the emergency department with a severe symptomatology. So diagnosis of COPD exacerbations relies exclusively on the clinical presentation of the patient, complaining of an acute change of symptoms, that is beyond normal day-to-day variation. That is the most important thing. There should be a diagnosis of COPD in this patient, and these COPD patients complains of an exacerbation of their symptom in the form of increased breathlessness, increased sputum volume, and increased sputum purulence, which make them attend a healthcare facility to change the treatment protocol. That is exacerbation and diagnosis of exacerbation. But we can do certain simple things before going in for the treatment, and it can be divided into 4 steps. Number 1 is appropriate medical history, which identifies one or more of 3 cardinal symptoms. The 3 cardinal symptoms which I have mentioned is increased dyspnea, increased sputum volume, and increased sputum purulence. If these are there, it is an exacerbation. And frequency of previous acute episode. If the patient had similar episode in the past, especially more than 1 or 2 episodes in the last 1 year, is important to make this a COPD exacerbation. And presence of comorbidities, just comorbidities like pulmonary hypertension, cardiac failure, all those things worsen a COPD patient, making it an exacerbation. And the socio-economic environment of the patient, where the treatment is not properly followed up, then a chance of exacerbation is very high. Am I audible? Any problem?
No.
No, sir.
Too fast?
You're audible, sir.
No, no, it's perfect. It's
Yeah,
perfect.
because only 10 minutes is there. That's why
Yes,
I am
sir.
fast.
Yes,
Okay,
sir.
the step 2 is looking for respiratory signs of exacerbation. That is rapid and shallow breathing, use of accessory muscles, paradoxical chest wall motion, wheezing, attenuated or absent breath sound, hyperresonance on percussion, and pursely breathing. These are all things which we routinely look for a patient exacerbation. Then cardiovascular signs, evidence of right heart failure, peripheral edema, and hemodynamic instability, along with general signs such as altered mental status due to hypercarbia or central cyanosis due to hypoxemia. And step 3 is conditions associated with COPD. So you can have other conditions which worsens a COPD patients like pneumonia, pneumothorax, pleural effusion, lung cancer, upper airway obstruction, rift fracture. All these worsen a COPD in their symptoms. Then cardiovascular condition, important one are pulmonary embolism and right or left heart failure. And sometimes drugs can also cause sedatives and narcotics overusage can produce worsening of respiratory symptoms. And the 4th one is the real investigation of these patients. Number 1 is we are looking for an arterial blood gas analysis to look for oxygen status, carbon dioxide status, and pH. Then chest radiography is very important, especially bacterial infection causing exacerbations. We will be able to pick up pneumonia in these patients. A routine blood test, then ECG is important. Then most important is to take a sample for gram stain and culture when the sputum is purulent, which will tell you what exactly is the investigation and easy to treat these patients. And spirometry, many people advise that we should do a spirometry in COPD exacerbation. And in practical situations, we always find that it is very difficult to do a forced spirometry in these patients because they are all having severe symptoms and difficult to breathe. But so we cannot rely on a spirometry. Even if it is done, it will not be giving the correct values. But it is mandatory that once the patient is better or recovering, we can do a spirometry to confirm the diagnosis. And the patient's follow-up period also, spirometry is important to see how much lung function they have retained. But we can use peak expiratory flow rate in these patients as an alternative measurement, which is a predictor for peak FEV1, because if spirometry cannot be done, a simple measurement of peak expiratory flow will give you an idea about what exactly is expiratory flow. So these are the investigations. There are so many other investigations which we can do, like CT thorax, all those things we can do, but these are basically needed to treat a COPD exacerbation. And this is just to show you an X-ray of a COPD exacerbation. You can see the hyperinflated lung with a right lower lobe pneumonia. And pneumonia, you see that pneumonia, it is not typical dense consolidation. You can see the black pores within the pneumonia that is very clear in the CT scan. This is called cystis appearance because of the hyperinflated emphysematous lung. When there is exudation in the alveoli, it will not fill the alveoli completely. So there will be pores seen like that, which resembles a cystis. and it is called cystic appearance. And mentioned about the investigations, we'll go to the treatment goals. I will just cover the important points in the treatment only because we don't have that much time. The main goals are minimize the impact of current exacerbation. That is, impact we have already discussed. We will have to treat the patient exactly to reduce the impact on the patient. Second is to prevent complications. An exacerbation will produce hypoxemic respiratory failure, type 2 respiratory failure, increased pulmonary hypertension, core pulmonary, all this can happen in a patient. So we will have to look at these complications and prevent these complications. Third one is to prevent subsequent exacerbation. Any exacerbation is liable to bring another immediate exacerbation to the patient. So we will have to try to prevent exacerbation. These are the main goals of management of COPD exacerbations. So look at this diagram. We have three groups: mild to moderate, moderate to severe, and severe COPD. So when we have a mild to moderate COPD exacerbation, patient should be treated with bronchodilators, corticosteroid, and antibiotic with patient education for further treatment. And if it is moderate to severe, we'll have to add supplemental oxygen. And if it is very severe COPD exacerbation, we may need respiratory support to this patient. So basically, to look at the management, these are the three options in three different severity categories. So the same thing is given in a different form: mild, moderate, and severe. As the severity increases in the exacerbation, we treat the patient, start with bronchodilation, optimize the dose of bronchodilators, put a patient on the antibiotic, then is it a little more severe, put systemic corticosteroid, and then go into severe for hospitalization, ICU assisted respiratory support. So these are the things which we usually take care of a patient with COPD exacerbation. But to say that even though hospitalization is planned, more than 80% of exacerbations can be managed on an outpatient basis with pharmacological therapy. That means only 20% of exacerbation need real hospitalization. 80% can be managed at home with bronchodilators, corticosteroids, and antibiotics. This is the gold guideline. COPD management, I don't know whether it is very clear, but I have copied it. Initiate or increase short-acting bronchodilator therapy and consider antibiotic in all exacerbations. Reassess within hours if there is no improvement, add oral corticosteroid. Then reassess the patient within hours and exclude any other complication. If there is worsening of signs or symptoms and respiratory failure, refer the patient to hospital. If by the initial treatment, if the patient improve in the signs and symptoms, continue management and step down whenever possible, and review long-term management of these patients during follow-up. So what are the indications for hospital admission in COPD patient? That means only 20% of COPD exacerbation need a hospitalization. So severe underlying COPD with frequent exacerbation need hospitalization. The patient coming with an exacerbation with a history of previous 2 episodes in the last 2 or 3 months, then the patient should be admitted. Inadequate response to OPD or home management, inability to eat or sleep, that is day-to-day activities if affected, we will have to admit the patient. Onset of new signs such as edema or cyanosis, home support not available. If the patient has no home support, like nobody to take care of the patient, to give him drugs or medicines or food in time, or if needed to get a medical help, such situations, it is better that the patient should be admitted. Presence of comorbidities like a pneumonia or left heart failure should be admitted. And if there is a diagnostic uncertainty of the exacerbation, then again, we should admit and plan investigations. Older aged patients should be admitted, and patients having altered mentation, worsening hypoxemia, worsening hypercarbia, or arrhythmia should be admitted. And new or worsening core pulmonary also should be admitted. So these are the basic indications for admission in the hospital. And when we put the patient on antibiotic, a patient should be put on antibiotic if all the 3 cardinal symptoms are present. And if only 2 are present, there should be sputum purulence. Then put the patient definitely on antibiotic treatment. And the third indication for antibiotic is severe exacerbation, which require mechanical ventilation. So if the patient is put on mechanical ventilation, we should put on patient on antibiotic. So these are the 3 important indications for antibiotic. the presence of purulent sputum during an exacerbation can be sufficient indication for starting empirical antibiotic treatment. The recommended length of antibiotic therapy is usually 5 to 10 days. The choice of the antibiotic should be based on the local bacterial resistance pattern. So these are the broad guideline for antibiotic. If the usual uncomplicated COPD exacerbation, we can start with azithromycin or any macrolide, doxycycline, trimethoprim or amoxicillin. This is a simple antibiotic. The patient has got risk factors for a complicated exacerbation such as severe COPD, more than 3 exacerbations in a year, antibiotic use in the past 3 months, then we'll have to go for higher antibiotic like amoxicillin clavulanate, levofloxacin or moxifloxacin. And when we put the patient on antibiotic treatment, improve, when we discharge the patient, there is a question of long-term azithromycin in this patient to prevent further exacerbation. That is being practiced in many areas and is given. A lot of articles are available now, like long-term azithromycin is well tolerated, associated with significant reduction in AE-COPD. So to prevent exacerbation, to prevent hospitalization, and to reduce the length of hospitalization in patients with severe COPD, azithromycin on a long-term basis is given, either 500 milligram twice weekly or 250 milligram daily is continued for 1 year or more in these patients. Then the patient is Pseudomonas, at risk of Pseudomonas infection, which you can see here, 4 or more courses of antibiotic in the past year may develop Pseudomonas infection. It's very severe COPD, recent hospitalization in the past 90 days, isolation of Pseudomonas during the past hospitalization. All these are risk factors for Pseudomonas infection. And this patient should be put on high-dose levofloxacin or ciprofloxacin. I don't agree with the levofloxacin, even though it is given in the guideline, but ciprofloxacin is definitely an anti-pseudomonal antibiotic, antibacterial drug, which is very useful in clinical practice. So to narrate this again, uncomplicated and complicated, we have simple bacteria producing the pneumonia. Then the group 2 is group 1 plus gram negative, and group 3 is group 2 plus Pseudomonas aeruginosa. So we can divide the patient in these 3 categories and basically put on fluoroquinolones depending upon which type of organism is there. Or we can go for advanced macrolides, 3rd generation cephalosporin or beta-lactam inhibitor. If it is a risk factor for Pseudomonas, definitely think of ciprofloxacin or anti-pseudomonal penicillins. That is the antibiotic preference. Then second important, it is not second, the first important drug is bronchodilators, because adequate bronchodilation is needed in all these patients. See, this improves symptoms and FEV1. It can be given as MDA or nebulization. Most of the studies say that nebulization and MDA are equivalent. So use a beta-2 agonist and increase dose as per requirement. And add anticholinergic if needed. If the patient is not improving, add the second drug as anticholinergic. So the 2 drugs can be given. Theophylline is only given as a 3rd preference. Theophylline only to be used as second line drug. It is not preferred in most of the cases. So inhaled bronchodilators, short-acting beta agonists can be given in the dose given here. And the short-acting anticholinergic can be added as a add-on drug when the patient is not improving. So 2 drugs can be given. And now they say that it can be supplemented by a 3rd drug like inhaled steroid. And the 4th drug like theophylline. So depending upon the symptom improvement or symptom worsening, we can increase, optimize the bronchodilation by 1, 2, 3 or 4 drugs. And now apart from SABA and short-acting anticholinergic, now the preference is going for long-acting LABA and LAMA combinations. So it is better that they have long-acting drugs. They have short initiative period and long duration of action. So LABA and LAMA combination are better preferred. Even if the patient is given a short-acting drug during the immediate hospitalization, it can be followed up with LABA and LAMA, or even now ultra LABA LAMA combinations are being preferred in most of the studies. So they are well tolerated and added clinical advantages there. So we can always think of choosing this medication on a patient-to-patient basis rather than blindly saying that SABA is better, LABA is better like that. The third important drug is corticosteroid. Systemic corticosteroids are recommended in hospital management of AECOPD. Shorten the recovery time, improve lung function and hypoxemia, reduce relapse, treatment failure, and length of hospital stay. It is oral is as good as intravenous drug. 40 milligram prednisolone daily into 5 days is given, and certain studies say that should be given for 14 days in a tapering dosage. So 5 to 14 days, certain studies prefer 14 days, certain studies say that only 5 days are needed. And oral prednisolone is equivalent to IV methyl prednisolone. And it can be seen in many studies that now inhaled steroids are also preferred, but it is not a substitute for systemic steroid. Whenever there is an exacerbation, systemic steroid should be given for a short period to reduce the symptoms, improve the pulmonary function, reduce the hospital stay, and prevent exacerbations, further exacerbation. But role of inhaled steroid are definite indications are there in inhaled steroid in COPD exacerbation, especially patient had 2 or 3 exacerbation previously. We should put the patient on steroid, or the patient has persistent symptoms, we'll have to put the patient on inhaled steroids. Or if the patient's sputum shows increased eosinophils, if there is an eosinophil level in the sputum is more, then that patient also needs inhaled steroids. And there are many studies, controlled studies comparing placebo, systemic steroid and inhaled steroids, and they say that systemic steroid cannot be replaced by inhaled steroid. Inhaled steroid indication is in eosinophilic inflammation, frequent exacerbators, and to prevent further immediate exacerbation. So indications are very clear here. And the last one for COPD exacerbation I'm mentioning is respiratory support. It can be of 3 types: oxygen therapy, non-invasive ventilation, and invasive ventilation. Oxygen therapy is needed in all patients coming with respiratory failure. So only thing is that COPD exacerbation, oxygen therapy should be a controlled oxygen therapy to titrate saturation between 88 to 92%. So we can use a Venturi mask with 24 or 28% of oxygen rather than giving 100% oxygen and worsen the situation. So there is a chance of worsening the situation if we over titrate the patient to look at 96 or 95% of saturation in this patient. And blood gas should be checked when the patient is on oxygen to see satisfactory oxygenation as well as carbon dioxide retention in this patient. Non-invasive ventilation is the standard of care for decreasing morbidity and mortality in patients hospitalized with COPD and respiratory. So non-invasive ventilation has actually it has replaced invasive ventilation, many other modality of treatment, because this is a standard of care in ICU for COPD exacerbation. Nobody wants to intubate a patient unless there is a real indication, and most of the patient improve with the non-invasive ventilation. It improves the gas exchange, reduces the work of breathing and need for intubation. It decreases the length of stay in the hospital and it increases the survival also. These are the important points in non-invasive ventilation COPD patients. And lastly, invasive mechanical ventilation is needed in a small subsection of patients who will not tolerate NIV or there is an NIV failure. The patient has got cardiac arrest or post-respiratory arrest status. The patient's consciousness is not normal, or the patient has got agitation. And if there is a massive aspiration or persistent vomiting, severe hemodynamic instability like shock, ventricular or supraventricular arrhythmia, and severe intractable hypoxemia. So these are the definite indication for patients to be intubated and put on invasive ventilation. We should remember that invasive mechanical ventilation brings a lot of complication in these patients, and before doing that we should ensure that these indications are there. Otherwise, patient can be easily managed by titrating non-invasive ventilation oxygen supports. That is my personal idea for treating COPD exacerbations. So with this, I am very much thankful to TAPCCM for inviting me to this particular session. Thank you very much.
Ravindran, for your nice lecture. Unfortunately, because of lack of time, otherwise we could have continued for some more time. Is Josh sir ready? Joy.
Josh sir, unmute your mic, Josh sir. Unmute.
Hello, Joshi sir. Please unmute your mic, sir. Sir, your mic is muted. Could you please unmute your mic?
If he is not ready, let us go to Dr. Anita Kumari.
Okay, sir. I will check with him, sir.
We'll go to Dr. Anita Kumari for viral infections exacerbation of COPD. Dr. Ajoy.
Yes, sir.
Please pick up Dr. Anita Kumari's slides.
Yeah, madam is started screen sharing, madam. Sir. Yes, madam. Now your screens are visible, sir. Ma'am. Hello, madam.
Dr. Anita, please continue.
Madam, you are not audible, madam. Madam, please unmute your mic. We can see your screen, ma'am, but you are not audible. Yeah, madam.
Am I audible now?
Yes.
Yeah, ma'am. Yeah, ma'am.
Very much.
So, good evening, respected Ravindran sir, respected Joshi sir, respected C. Ravindran sir, senior colleagues and friends. Let me first thank the organizers of this program, Dr. Preeti Nair, Dr. Kamala and Dr. Manu, for giving me this opportunity to talk on acute exacerbation of COPD with viral infection and antiviral treatment of H1N1 and COVID-19. So we all know that exacerbation of COPD is associated with a rapid decline in lung function and also significant mortality.
Next slide.
Yes. Till recently, bacterial pathogens appear to be the important causes of exacerbations of COPD. But of late, viral infections are being diagnosed in almost half of the cases of COPD exacerbations, as per certain studies. And with the advent of newer molecular diagnostic testing, newer viral infections are being diagnosed in exacerbations of COPD. And coming to the antiviral treatments, there's a long list of drugs that are being developed for the treatment of viral diseases. But due to paucity of time, I shall be talking on oseltamivir, which has got proven efficacy in H1N1, remdesivir, whose efficacy is being debated, and favipiravir, where there is no evidence. Now, we all know that COPD is a disease of heterogeneity, and historically we have thought about COPD as mainly by two pathogenic mechanisms. One is the protease-antiprotease imbalance, and the other one is related to the oxidative stress. And both these mechanisms come into operation when they are triggered by exposure to noxious particles and gases, particularly cigarette smoke. But it is found that some studies have shown that there is an increased number of T lymphocytes and also B cells, which actually accumulate and form lymphoid follicles in the epithelium. So that is suggesting an immune surveillance mechanism that is going on in the airway mucosa. And this is the culprit for this particular change is possibly viral infections. So viral infections are now thought to be the missing link in the pathogenesis of COPD. And the respiratory viruses, they particularly target the respiratory epithelial cells, leading on to sloughing of the epithelium. They cause goblet cell hyperplasia and mucus plugging. and also causes microvascular dilatation leading on to edema and decrease in the mucociliary clearance. And therefore, there is a predisposition to bacterial infections also. There is increase in the cytokines and chemokine levels, and all these cause an influx of a large number of inflammatory mediators like the neutrophils, macrophages, eosinophils, the T lymphocytes, B cells, and even the dendritic cells. And to add to that, cigarette smoking causes a decrease in the interferon levels and the interferon stimulated gene production, leading on to airway remodeling, and also a decrease in the innate immunity to viral, the protection from viral infection. So that also is hampered, and also the adaptive immunity. Therefore, the patient develops frequent viral infections, and the pathogenesis of COPD comes into action. And the importance of this it is important because we do have, as mentioned by the previous speakers, we do have a large number of COPD exacerbations which are not related to the bacterial infections. Also, COPD seems to be developing in patients who are smokers. And looking at the prevalence of viral infections in acute exacerbation of COPD, this is a meta-analysis. And here, the most common virus was found to be picornavirus. And this is followed by rhinovirus, then adenoviruses, the other coronaviruses, and influenza virus. Possibly this data came before the present pandemic. And looking at the data that we have from this part of the world, the only data that I could get was from Dr. Arjun's study, and that is not related to COPD exacerbations, but to viral infections causing community-acquired pneumonia. And here it was found that influenza was the most common virus as virus-related risk. Human metapneumovirus, respiratory syncytial virus, parainfluenza, corona, and adenovirus. So we know that SARS coronavirus 2 uses the angiotensin converting enzyme 2 as a cellular entry receptor. So it is known that the virus can infect individuals of any age, but most of the severe cases have been described in those who are above the age of 55 years with significant comorbidities, particularly COPD. So is it because there is an increased expression of the ACE2 receptors in the bronchial epithelial cells in by bronchoscopic cytological brushings were taken, and the total RNA was expressed, and the ACE2 receptor expression was studied by genomic techniques, and they found that both in smokers and COPD patients, there is an increased expression of the ACE2 receptors. And you can see that looking at the scatter plot there is an inverse correlation with the FEV1 also. So this may be one reason why there is an increased predisposition to develop severe COVID in these patients. So it also points to the importance of smoking cessation in these patients, especially for the COPD patients and smokers, and also a need for improved surveillance in these patients for early diagnosis and treatment so as to prevent mortality. Now, regarding the treatment of H1N1, this is based on the revised protocol which came out in February 2019 from the National Center for Disease Control India. And protocol mentioned that one drug, namely one category B and C patients, dosage we all know is 75 milligram twice daily, and the weight-based doses are also mentioned, so also the dosage for infants. And coming to the treatment of COVID-19, the antiviral drug that has been studied is remdesivir, and the final report came out early this month. It was published in the New England Journal of Medicine. So a total of 1,062 patients were randomized and 541 patients received remdesivir. The median recovery time was 10 days in the remdesivir group as compared to 15 days in the placebo group. Also, those patients who received remdesivir had greater clinical improvement at day 15. as compared to the placebo group. The mortality rates were also less with remdesivir as compared to placebo, but this was not statistically significant. And the Solidarity trial looked at the repurposed drugs for COVID-19, and this was undertaken by WHO. This is a multi-center, multi-country study done in 405 hospitals in 30 countries. 11,266 adults were randomized, of which 2,750 received remdesivir. The other drugs studied include hydroxychloroquine, lopinavir, and interferon. The overall 28-day mortality was 12%, and the death rate ratios of each drug is given here. It is found that no study drug definitely reduced mortality in ventilated patients or any other subgroup of entry characteristics, did not reduce initiation of ventilation or hospitalization duration. So remdesivir, hydroxychloroquine, lopinavir, ritonavir, and interferon regimens appeared to have little or no effect on 28-day mortality or the in-hospital course of COVID-19 among hospitalized patients. So what was the response from the manufacturers of the drug? So they challenged the methodology of the Solidarity trial, saying that this is an open label trial and had not undergone the rigorous review that is needed. And they were only willing to accept the results of the randomized double-blind placebo-controlled trials, including the ACT-1 trial. So being the manufacturers, this is the response that is expected. Now, moving on to the next drug, favipiravir. We did a very extensive, exhaustive literature search, but we could not come across even a single RCT this particular drug. But still, it has found its way into the most of the guidelines. And we have all been taught by Ravindran sir about evidence-based medicine. He has always stressed on this particular thing. But you can see that favipiravir is approved for use in countries like in China, Russia, but not by UK, US, or even Japan, where this drug was actually manufactured. So look at the guidelines, the Kerala guidelines, which was updated on 15th August 2020. It mentions that for category C patients, give hydroxychloroquine plus favipiravir at a dose of 1,800 milligram twice daily for 2 doses, and then 800 milligram twice daily for a total of 7 to 10 days. And for category C patients with moderate severity, the drugs include injection remdesivir plus steroid, anticoagulant, and convalescent plasma. And those with severe signs and symptoms, we use remdesivir plus steroid, anticoagulant, and convalescent plasma plus tocilizumab. So to conclude, viral infections are major causes of exacerbation of COPD, and H1N1 infection and COVID-19 are dreaded viral infections. The antiviral treatment for H1N1 is clear, but we do have very little evidence regarding effective management of COVID-19. Thank you.
Thank you, Dr. Nida, for a nice but short presentation of the available evidences in viral infections with acute respiratory, acute exacerbation of COPD. I now invite Dr. Jayaprakash to which one is the best for early diagnosis of ARDS with the COVID, with COPD exacerbation going on to ARDS, thoracic ultrasound, CT scan.
Excuse me, sir. Sir, I think Joshi sir is ready with the presentation now.
All right, please come.
Jayaprakash sir, can we allow Joshi sir?
Sure. Please,
Okay.
please. No, sir.
Okay. Joshi sir, am I audible? Yes, sir. Your screen is being shared now, but your audio is not still clear. Hello, sir. Sir, you're not audible, sir. We can see your screen, but you're not audible, sir. Sir, just go to the Zoom, just the Zoom icon, just beside the Google Chrome. Sir, below the bottom part, just beside the Google Chrome, there's a Zoom icon. Just click on the Zoom icon, sir. Below, sir, below. Yeah. Just click on it. Sir, is there a mute or unmute screen? Sir, close this window, sir. Close this window. This current window, close it. So this window, you can close it and you can open the Zoom app. Yes, sir. Close the whole window. No, sir. The whole window, you have to close the whole thing. On the right hand side. Yes, sir. Just click on the Zoom app, sir. Zoom.
Zoom app എവിടെ? Zoom app
Sir, right click on the Zoom app and just right click on it, sir. Yeah. You can just yeah, click on that, sir. Yeah, you have to join the meeting. No, sir. Join meeting. You have to click on that. Yeah. So click on the join meeting. Are you able to click on it? No. Just close it, sir. Then close it. Sir, we'll continue with the next talk, sir. Then we'll again check with Joshi sir once again.
Okay.
Devendra sir?
Yes, I'm ready.
Yes, sir.
Dr.
Yes, sir,
Jayaprakash, ready?
Joshi sir has to close the window, then only I can share.
Okay.
Joshi sir has to close the
Joy.
screen, then only I can do
Joy,
it.
please inform yourself to close the
Yes, sir.
screen.
Joshi sir, could you please stop your screen sharing? I think there are two icons in that Zoom app, sir. Next to your PowerPoint, there are two windows are there in the bottom part. Yeah. Now, sir, has stopped screen sharing. Jayaprakash sir, over to you, sir. Yes, sir. Now your slides are visible.
Full screen visible?
Yes,
Yes, sir.
you're visible.
Respected Ravindran sir, Joshi sir, and C. Ravindran sir, and my dear friends and colleagues, I express my sincere thanks to TAPCCM President Preeti Nair, Secretary Manu, and President Kamila for giving me an opportunity to talk on this small topic. And as Ravindran sir, the chairperson, pointed out, I will be speaking on COPD with respiratory infection or pneumonia. Going for ARDS, what is the use of ultrasound and CT scan? That is the topic I am going to speak on. As you know, C. Ravindra sir just has pointed out that bacterial infections are very common in COPD patients to the tune of 40 to 60%, and lead on to acute exacerbation of COPD. And whenever there is severe exacerbation, there is a chance of ventilator requirement to the tune of 70%. And as most of you are aware, the common organisms producing infective exacerbations are H. influenza, Streptococcus pneumonia, Moraxella, Haemophilus, Pseudomonas, etc.
The literature says that Pseudomonas is only 4%, but our own data from our department, one of the postgraduate thesis showing that 34.7% of our bacterial infections, patients had bacterial infections. Now, out of which the commonest organism was Pseudomonas, it was 10%. Possibly because of the severity of the COPD, maybe the underlying bronchiectasis or the previous recurrent infections. So our data a few years back showed that there is 10%. The significance is if there is 10% Pseudomonas, there is a high chance of patient going for ventilator recommend and severe respiratory infection leading to the possibility of ARDS. So as C. Ravindra sir has pointed out, when there is a bacterial infection, you will be seeing some opacity in the chest X-ray, which is easy to diagnose. As he suggested, you can treat the patient with a course of antibiotics, it will subside. But when you get an X-ray which is showing bilateral patchy opacity, and this picture going to the second picture like bilateral patchy opacity, there is a desaturation. One would suspect that the patient is going for a complication or the possibility of ARDS. And Ravindra sir, P. Ravindra sir always teaching us that clinical examination is the most important step. So whenever there is a COPD patient with exacerbation coming to your emergency room or in the ward, first thing you look is, you look for the evidence of sepsis by a simple Q-SOFA score. Just look into three factors: the respiratory rate, the change in mental status, and the systolic blood pressure. And if the respiratory rate is more than 22 and there is an altered sensorium or a systolic pressure less than 100, any two of these present, one would suspect there is a possibility of impending sepsis and the patient has to be managed accordingly. That patient should be subjected for a sepsis marker like C-reactive protein lactate or procalcitonin. Always look for a saturation, and if there is a hypoxia, give oxygen. If the oxygenation improves, I think you are in the safe zone. If there is a refractory hypoxemia, the patient has to be subjected for admitted in a critical care unit or MDSU, and you have to do at least a blood anti-gas analysis. So coming to my topic proper, what is the role of an ultrasound in chronic obstructive? I will stress that clinical examination is one which is more important, but there is a role for ultrasound and CT scan. As you know, in COPD patient, because of the air trapping hyperinflation, you always get a poor ultrasound window for looking into the lung. And the use of ultrasound in COPD patients are, when there is a moderate to severe COPD, the diaphragmatic movements are decreased, the diaphragmatic excursion is decreased, the thickness will also increase. And in normal ultrasound, you will see a profile that I will be coming later. And whenever you see a hyperechoic area in the ultrasound in a COPD patient, that leading to the evidence of a consolidation or a possibility of a mass fusion. So when there is an infective exacerbation and the ultrasound showing a hyperechoic area, the possibility of secondary infection has to be thought of. And all patients with the COPD exacerbation, one should look for evidence of pleural effusion, whether it is unilateral on the side of consolidation or it is bilateral. That will help you to differentiate between a coexistent congestive cardiac failure or the possibility of a pneumonic effusion. And there is an important ultrasound feature called the B profile, which I will be coming in the next few slides. This is what I was referring to. In a normal patient, you will be seeing lines which are actually horizontal to the chest wall or into the ultrasound probe. You will get multiple horizontal lines, that is called A lines. These are due to the normal reverberations in the lung, and it is actually a normal phenomena in the chest ultrasound. And in patients with COPD, the diaphragmatic thickness will be, this is the M mode and this is ultrasound B mode. You can see the diaphragm is very much thickened. The distance from the chest wall to the diaphragm is very much increased in patients with COPD. Actually, this indicates there is an emphysematous changes. And when there is a respiratory infection or a bacterial infection with features of sepsis, if your ultrasound is showing a consolidation or a high attenuate area with some air markings or air bronchogram, the possibility of a dense consolidation is to be thought of. And if there is a consolidation with high attenuating spots inside and there is a pneumonic effusion, that patient, the chance of going into sepsis and ARDS is very high. So whenever there is a consolidation with dense consolidation or a high attenuation with pneumonic effusion, you have to be very careful of, because the chance of ARDS is very high. And coming to the features of ARDS in a patient with COPD and ARDS, we can look for multiple Am I audible?
Yes, sir. Yes, sir. Yes, sir. You are
Okay.
audible, sir.
So
Very well. Very well.
in COPD with ARDS, if your ultrasound is showing multiple B lines instead of the A lines, that is actually a warning sign. And the other features which you see in an ARDS patient with the COPD is you'll be seeing subpleural or consolidation in the subpleural region. The normal lung sliding strain will be decreased because of the congestion or the edematous lung, or the pleura can be irregularly thickened. So these are the features you look for in a patient with a respiratory infection with COPD. If any one or two of these are finding, the possibility of ARDS is very high. And this is actually multiple lines which are actually vertical lines rather than the A lines which are horizontal. You will be seeing multiple lines starting from the chest wall into the diaphragmatic area. If you see more than two or there are multiple B lines, that indicates there is a possibility of lung congestion, either edema, either pulmonary edema, or there is an ARDS, or the possibility of a fluid overload. So in the background of a respiratory infection, when there is multiple B lines, that indicate the patient is going for ARDS, and the chance of mortality is also very high. And there are few studies showing that B lines, if it is seen in multiple numbers, has a very high sensitivity to the tune of 100% and the specificity of 94% for diagnosing congestive cardiac failure. But if that patient has a consolidation with pleural effusion and there are B lines, that favors the possibility of an impending ARDS, you should be careful of. And this is actually a very interesting study which came from Italy. What they did was, when they take patients from home to the hospital, on the ambulance, inside the ambulance, they use a portable ultrasound. And if they find a consolidation with a few B lines, they think that it's a COPD exacerbation and the patient is shifted to a respiratory care center and even managed as COPD exacerbation. And if there is a bilateral effusion with multiple B lines, they make a diagnosis of congestive cardiac failure and the patient shifted to a cardiac center and even as cardiac failure. And they found that this pre-hospital ultrasound was a very useful tool in making a diagnosis of differentiation between COPD exacerbation with impending sepsis or a pulmonary edema. That actually the reference is in the critical ultrasound journal 2008. It's a very interesting. You can go to that article. And this is another article which came in the Journal of Emergency Trauma and Shock 2019. Actually, this is a study from India, and one of the authors is from Tiruvalla Pushpayari Hospital, and the rest of the others are from other centers of India. And the first image shows there are multiple normal A lines. When there is consolidation, as in the last right side of the image shows multiple consolidation, and there are multiple B lines, the possibility of ARDS is high. But when the B lines coalesce together, if you see that picture, when the A lines coalesce together and producing a coalescent B line, the chance of sepsis or severe ARDS is very high. And they concluded that when you have a COPD exacerbation with the B lines and consolidation, the possibility of a mild ARDS is there. But when you see more number of convalescent B lines, they call it as double B lines or convalescent B lines, the chance of ARDS is severe ARDS is high. So depending upon the number of B lines, as the ARDS progresses, the B lines number will come down and the coalescent B lines or double B lines will increase. That's also a very interesting study which came from Kerala. So as C. Ravindra sir pointed out, you will see this is a normal emphysematous central lobar emphysema of a CT of a COPD patient. And when they get a secondary infection, as sir pointed out, that will have a totally different appearance, which we call it as a Swiss cheese appearance or a pseudo honeycombing. And this is only because of the exudation building in the dilated alveoli. It will exactly mimic like a pseudo honeycombing. This will take a more time. And when you see this CT picture, the chance of patient going for sepsis is very high. Now coming to ARDS CT picture, all of you know that the CT will show bilateral high attenuation or opacity in the subpleural bibasilar region, and there will be some aerating lung, which is called the baby lung, which will be giving oxygenation to the patient. And the major difference of ARDS in pulmonary COPD patient and extrapulmonary focus of infection is that because of the emphysema and because of the lung focus, you will get a totally asymmetrical ARDS. Here you can see the right lung is more involved than the left lung. So when you get a pulmonary ARDS or a COPD ARDS, the ARDS picture in the lung will be asymmetrical. But when the infection is outside the lung, like maybe an urinary infection, urinary tract infection, or something like that, the ARDS will be totally a symmetrical picture. So from that itself, you can differentiate between an acute exacerbation of lung or maybe an extrapulmonary site of infection. So to conclude, infection leading to ARDS is a very common phenomenon in COPD, and lung ultrasound and CT test are useful tools in the diagnosis of ARDS, at least in the research purpose, or you can use it in ultrasound. But don't forget, a clinical examination with a Q-SOFA score, looking into the SpO2 and an ABG remains the gold standard for diagnosing and impending ARDS or a full-blown ARDS. Thank you very much. Thank you for the patient listening.
Thank you, Dr. Jayaprakash, for very concisely dealing with both your ultrasound and the differentiation patterns of ARDS in different parts from the different parts of extrathoracic and intrathoracic lesions. Now, Dr. Madhu will talk on some points on the critical care because he wants a lot of time. Otherwise, he cannot make a full impact on the talk. So, for the points he is going to talk, let him talk.
Good evening to you all. First of all, thank you to TAPCCM for inviting me for this talk. COPD in critical care. As such, there are not many changes in your routine management, but I would just like to touch upon a few points, like certain questions that we have in COPD with COVID. Is there an increased risk for COPD patients? Is there an increased risk for COPD patients for COVID infection? But data suggests otherwise. About 2% of hospital admissions with COVID have hospital admissions, but shy to 13% of COPD prevalence is seen in the Wuhan cohort. But this does not mean they are not of high risk. Both COPD and smokers have high risk of dying due to COVID infections. And regarding treatment of acute exacerbation, it seems that the diagnosis of COVID-19 with COPD does not preclude concomitant acute exacerbation of COPD, because both follow different pathophysiological pathway. Acute exacerbation is different from a pneumonia aspect, so it doesn't seem to be having a two. Both of them do not need. It doesn't necessarily mean that an acute exacerbation of COPD will happen with COVID infection. So the specific treatment for both should be followed as based on symptoms, and antibiotics is recommended for acute not recommended in all cases of acute exacerbation of COPD. But when there is COPD with respiratory failure with COVID infection, antibiotics, empiric antibiotic is currently recommended. And usage of bronchodilators, the BTS guideline says that there is no evidence to support an increased risk of viral transmission with nebulizers, but the sample sizes are small, so currently there is no consensus on this, but a conservative mode of approach is by everybody is using pressurized meter dose inhalers with spacers, preferring long-acting dual bronchodilators when the exacerbation is not severe. And coming to whenever we cannot use these meter dose inhalers, you should consider nebulizations. And regarding the use of corticosteroids, recovery trial, which is has shown that the 6 milligram of dexamethasone once daily is of benefit, and hence in COPD with COVID also, when there is exacerbation, we should consider 6 milligram of dexamethasone. Coming to ventilatory support, of the 14% of patients who have severe disease will require oxygen therapy, and 5% of them would land up in the ICU, and even lesser number on ventilatory support. And the preferred mode of initial treatment is HFNC or CPAP with high FiO2. When you're using HFNC, because of the high flow rate, you have to consider putting a surgical face mask over the nasal cannula. And regarding patients with hypercapnic acute on chronic respiratory failure, NIV should be your first line of ventilation rather than HFNC. And you should always use a non-vented mask with bacterial viral filter. And coming to invasive mechanical ventilation, it is indicated in severe hypoxia and when there is NIV failure. But acute exacerbation of COPD on invasive ventilation itself carries high mortality. And with COVID on ventilator having even higher mortality, you should weigh your decision very carefully before putting a patient with COPD acute exacerbation with COVID. These are some of the points I would like to clarify, and I would like to conclude my talk with this. Thank you.
Thank you, Dr. Madhu. Now I go to Dr. C.S. Ghosh for the economic impact of COPD exacerbation. Dr. Ghosh, can you hear?
Ghosh, sir. Yes,
Dr.
sir. Now,
Ghosh?
yes. Yes, sir.
It's not seen.
Ghosh, sir has started screen sharing. Yes, sir. Now, yes, sir. Now we can see your slides, sir.
So, first of all, let me thank Dr. Preeti Nair and her team for giving us an opportunity to have a very useful symposium on COPD in this World COPD Day, and also inviting most of the faculties in our center, in our place, as well as far places like Wayanad. I should thank her for organizing such a nice meeting, and also I should thank Professor Ravindran for chairing this session. Dr. Devi Satthi. Can you see my window?
No,
No, sir.
sir. Your slides are not visible now, sir.
It was visible earlier.
What happened?
No, not visible.
Slides. Okay.
No, sir.
Not yet.
No, sir. No, sir.
इतने बड़े बड़े सब
Just you need to share again, sir.
ये वो बड़े बड़े
Okay. Now is visible now?
No.
No.
No, sir.
Sir, you'll have to stop sharing and restart.
Stop sharing.
Screen sharing is with the video in the sir. അതുകൊണ്ടാണ്.
So your screen was being seen earlier. Just continue with the same way.
Zoom से लाइव मारना है
सर का इंटरनेट का इशू है सर, इसके लिए वो टाइम ले रहा है, बार बार फ्रीज हो रहा है, इंटरनेट का इशू।
तो क्या करना है, आगे जाना है?
This internet connectivity is slow.
या कनेक्टिविटी इशू सर।
Sir, I think we should all mute our video also for good.
Yes, everybody else should mute the video so that the bandwidth,
सर
more bandwidth will be
एक्चुअली
available.
वो डॉक्टर घोष सर का इंटरनेट का इशू है सर, बाकी लोगों का कोई प्रॉब्लम नहीं है सर।
Okay.
अपना ऑन करके रखिए सर, कोई इशू नहीं है।
Sir, I think Ghosh sir has logged out. He's trying to log in once again.
सर वो डिस्कनेक्ट हो गया, उनका इंटरनेट बंद गया हो गया सर।
Okay, sir.
तो
Devendra sir, shall we move with the next presentation then, sir?
Of course, we'll move without wasting time. Next is Dr. M. Ravindra Nair. Prevention, vaccination in H1N1, pneumococcus, and COVID-19. Dr. Ravindra Nair, can you hear me?
Yes, sir. Yes, I can hear you, sir.
I can see you also here.
Right.
Your screen, please. Slides. Yes.
Yes, sir. Visible, sir.
Okay. So let me first of all place on record my sincere thanks to TAP CCM office bearers, especially Dr. Preeti Nair, Dr. Manu, and Dr. Kamala for extending me this unique opportunity to be a part of this CME program being organized in connection with the World COPD Day. Now, I straight away proceed with my topic is prevention. So as we all know, prevention is always better than cure. So we know that COPD patients are at risk of developing acute exacerbations due to viral and bacterial infection. We have already seen the other speakers alluding to these things. A new study that has been published in the January issue of CHEST 2020 has shown that patients with COPD face heightened risk of death, critical illness, and hospitalizations if they develop influenza, and demonstrated the beneficial effects of yearly flu shots. It was seen that 1 out of every 10 patients with influenza died, and 1 out of every 5 COPD patients with influenza required ICU care. A meta-analysis of 20 cohort studies among older populations showed a 56% reduction in respiratory illnesses and 50% reduction in hospitalization rates with yearly flu vaccinations. Yearly flu vaccination was associated with a reduced risk of all-cause mortality in COPD patients. Also, it has been found that long-term benefits of seasonal influenza vaccination include reduced number of exacerbations, reduced hospitalization, decreased all-cause mortality, and respiratory mortality. Now coming to the flu vaccination proper, as we know, there are many different strains of influenza virus. Type A viruses cause the most severe disease and is associated epidemics and pandemics. Spontaneous mutations in the viral surface proteins, that is heme agglutinin and neuroaminidase, are responsible for the so-called antigenic drift. If this translates into the changes of the viral amino acid structure, pre-existing antibodies might be unable to bind to the viral particles to a sufficient extent to prevent the disease. This is responsible for the annual influenza waves encountered world over. Now, ERS, the European Center for Disease Control, and ATS recommends yearly flu shots to people to increase the risk of complications due to influenza like COPD patients. The gold also endorses this. Influenza vaccination reduces serious illness and death in COPD patients. What are the types of vaccines? We have the trivalent inactivated influenza vaccine, the quadrivalent inactivated influenza vaccine, and it is recommended in preference to the trivalent version. And also we have the live attenuated influenza vaccine, is usually used by the nasal route, but it is no longer used in India and it is not available also. So the usual dose is a single dose given annually and given intramuscularly. Now, coming to the safety profile, it has an excellent safety profile. The Advisory Committee on Immunization Practices, CDC, recommends the inactivated influenza vaccine for even those with egg allergy. Only you need to be a little more careful. Guillain-Barré is extremely rare but considered as a precaution for future vaccination. If an individual has a history of Guillain-Barré syndrome within 6 weeks of previous flu shots, he should not be vaccinated. Again, multiple sclerosis patients and those on antivirals can receive the flu shots. Long-term oral inhaled steroid therapy should not preclude the administration of the inactivated influenza virus. Am I audible, Dr. Ajoy?
Yes, sir. Yes, sir. You're audible, sir.
Slides are visible to you.
Yes, sir.
Yes.
Can I proceed?
Yes,
Go
sir.
ahead,
Both,
go ahead.
both. Yeah.
Now,
Very
coming
good.
to statin therapy, though statins have the potential to reduce the effectiveness of flu vaccine, the most experts all over the world recommend the use of the inactivated influenza virus vaccine. Now, coming to the timing, it is recommended to have flu shots from September to October for those regions with temperate seasonality and April to May for those regions with peak monsoon season. This UPP means the usual practice point, but there are no results from RCTs. So moving on to the pneumococcal vaccine. Now, COPD patients are about 20 times more likely to contract community-acquired pneumonia compared to the general population. Pneumonic exacerbations of COPD tend to be more severe than non-pneumonic acute exacerbations with hospitalizations averaging 9 days for pneumonic versus 5 days for the non-pneumonic flares. The cost of treatment for pneumonic flares is twice as high than those with non-pneumonic flares. Preventing lower respiratory tract infection also prevents exacerbations in COPD patients. So coming to the vaccines that are available, we have the pneumococcal polysaccharide 23-valent vaccine, and so this has been shown to reduce the incidence of community-acquired pneumonia in COPD patients aged below 65 years with an FEV1 of less than 40% predicted and in those with comorbid conditions. In the general population, adults more than 65 years, the conjugate 13-valent vaccine, pneumococcal vaccine, has demonstrated significant efficacy in reducing bacteremia and invasive pneumococcal disease. The Advisory Committee on Immunization Practices recommends the pneumococcal polysaccharide 23-valent vaccine for all patients above 65 years and advises clinicians to engage in shared decision-making to determine whether this conjugate 13-valent vaccine should also be given besides this 23-valent polysaccharide vaccine. When both vaccines are considered, ideally the conjugate 13 should be given first, followed by the polysaccharide 23-valent vaccine 1 year after. However, for those with perceived higher risk of pneumococcal disease, it can be given after a gap of 8 weeks. Now, both are administered in a dose of 0.5 intramuscularly. Now, concurrent administration of the polysaccharide vaccine with flu vaccine is found to be safe and does not alter the effectiveness of either vaccines. Co-administration of the polysaccharide 23-valent vaccine and the recombinant zoster vaccine, which is now currently available, also doesn't alter the antibody response to the polysaccharide vaccine. Efficacy. As for the meta-analysis of about 18 RCTs, it was observed that the polysaccharide 23-valent vaccine reduced the risk of invasive pneumococcal disease with an odds ratio of 0.26 with a 95% confidence interval between 0.14 to 0.45. Again, was associated with a substantial reduction in both invasive, then odds ratio 0.26, 95% confidence interval between 0.15 to 0.26, and non-invasive pneumococcal pneumonia. Now, then finally coming to the COVID-19, now COPD patients are at higher risk of severe disease when they are infected with the SARS-CoV-2. Now, we should also remember that these COPD patients at risk of developing both influenza and COVID-19. Now, in many parts of the world, it is the season of influenza. But however, no vaccination is currently available for the novel coronavirus. However, there are about 150 coronaviral vaccines in different stages of development, and the various manufacturers are in a hurry to get the expanded the emergency use authorization from the FDA. So they have now come out with expanded access protocols versus the emergency use authorization for a COVID-19 vaccine. Operation Warp Speed initiative, they are aiming about 300 million doses by January 2021. The WHO is aiming at 2 billion doses by the end of 2021. Typically, remember, a vaccine in the past decade took about 10 to 15 years to be in the field, and the vaccine that got with the shortest time period was mumps vaccine, which took about 4 years. But now we are going to have a vaccine for COVID-19, a record time of less than a year. So there are 4 frontrunners. So the BNT162b2 vaccine, which is being developed by Pfizer along with BioNTech. In phase 3 trial, it has enrolled about 42,000 participants, and the result of the interim analysis, they show that their vaccine is effective to the tune of 90%. Say, messenger RNA vaccine, and the disadvantage is that it has to be kept at a temperature of -70 to -80 degrees centigrade. And another messenger RNA vaccine, that is 1273 vaccine, developed by Moderna in association with the National Institute of Allergy and Infectious Diseases. It is the Moderna that they have enrolled about 30,000 participants, and the one advantage is that they have enrolled all types of patients above the age of 65 years, patients with all comorbid conditions of varying ethnicities. And so they have, in the interim analysis of the efficacy, it is said that their vaccine is effective to the tune of 95%. 2 doses are required at 4 weeks apart. Then another, the AZD 1222 vaccine developed by AstraZeneca and Oxford University. Again, they have enrolled about 30,000 participants. Then another vaccine in the front line is AC126 COVID 2.5 vaccine that is developed by Johnson & Johnson. It's a single dose, and this is the one that has enrolled the maximum number of participants. It is 60,000. And then we have from our own country, we have the Covaxin being developed by Bharat Biotech, 2 doses at 2 weeks interval. Now, so FDA has decided to set a median follow-up duration at 2 months in phase 3 trials in view of the expected emergency use authorization applications for COVID-19 vaccine. So I think there is a huge queue before the FDA. That has prompted FDA to come out with this. So then another interesting thing, of course, a flu vaccine against the influenza virus may also trigger the body to produce broad infection fighting molecules that combat the pandemic causing novel coronavirus. Now, there is a growing body of research that suggests that a vaccine designed to protect against one particular infection could protect others too via what is called a trained immunity. I think the Priot has conducted a meeting on the immunity and aging, and in that Professor Ravindra sir has beautifully explained the role of what is called the trained immunity. That is the immunity that you can get with other vaccines that can also be used against infection with an unrelated infectious agent. So in general, vaccines work by triggering the adaptive immune system, produce antibodies. Recent studies have shown that some vaccines also train the body's faster acting and less specific innate immune system, enhancing its ability to fight off many kinds of infections by reprogramming the cells. So the association of this flu vaccine with this COVID-19 came from a study from Netherlands, and that is now in the preprint. And I think that this is a point which all of us can look into, because many of the pulmonologists in our state have a lot of patients who are taking yearly the flu shots. And I think looking back the data, you will see how many of the people who got this COVID-19 during this pandemic. So that is going to be a huge data from our country, our state and our association. So I think that with this, I will wind up, and thank you for your listening, hearing. Dr. Ajoy?
Thank you, Mr. Nair, for a fine presentation. And what has happened to Dr. Ghosh and Dr. Joshi?
I am ready.
Ghosh sir is ready. So we'll go ahead with Ghosh sir now.
Okay.
Yes.
Sir, Ghosh sir, could you please share your screen?
Can you see my screen?
No, sir.
Can see you.
We can see you, but we can't see your screen, sir.
You go to the screen share.
Screen share.
The green color.
Ravindra sir screen.
Ajoy?
Yes, sir. Otherwise, sir, could you please share the PPT with to my Gmail ID? I can project for you when.
Okay.
Joshi sir is ready with that. So we'll move with Joshi sir's PPT now.
Okay. I will do that.
Okay, sir. I will send you a message, sir, WhatsApp. Ravindra sir, we will move with Joshi sir presentation.
Your son, the audio, is it okay?
Audio, sir is trying to log in through mobile. So I will project the screen. Sir can. Joshi sir, could you please speak up? Joshi sir.
In that case, I think we will project a slide. Will it be okay?
Yes, sir. I have the slides with me.
I also have the slides.
Okay, sir. I can project, sir, but his audio is not yet correct.
This happens.
Joshi sir, can you hear me? So meanwhile, then, sir, we can move on with the next topic, sir, surgery in COPD. We will correct it, sir.
Asherenis Nayagram.
Yes, sir.
Hello, sir.
Yes, we can see you.
Your topic.
Okay, right.
Others are not.
Hello.
Ashish sir, could you please?
Yeah, I'll go to the slideshow. Yeah.
But your screen is not visible, sir. First, you have to screen share. You have to share your screen. Then only you have to go to your PowerPoint.
Okay. Is my screen audible?
Yes.
No,
You can
your
see
screen
screen?
is
And
not.
is it visible
Yeah, screen,
now?
you're audible. But
Yeah,
Okay.
now.
yes, it has come.
Yeah.
Now it has come.
Okay.
Yes, sir.
Okay. Good evening, everybody. So today my topic is surgery in COPD. So greetings from NIMS. So after all medical optimization, a symptomatic patient with an end-stage COPD is the only patient who requires surgery. So there are many types of surgeries which are introduced for this, but only 3 major surgeries which stand till date. And the first surgery is bullectomy. So in a COPD patient, there are multiple bullets or a large bullous or a giant bullous. All bullous doesn't require surgery. So mainly a large bullous, a giant bullous, which occupies more than 30% of the hemithorax with compression effects are the patient who are going to benefit with bullectomy. So mainly these bullous causes the compression of the normal parenchyma of the lung, so that they causes reduced blood flow and decreased ventilation. So bullectomies are initially done through thoracotomy, but which had high morbidity. Now minimally invasive like VATS and robotic surgery has taken over this. So the surgical part has been little more easier and with less morbidity. But still, this procedure has a high mortality of 2.5 to 7%. So what are the advantages of bullectomy? So this causes expansion of the compressed lung, so that it decreases the airway resistance, decreases the functional residual capacity, decreases the pulmonary vascular resistance. At the same time, it increases the elastic recoil pressure, the dynamic compliance, and it allows the chest wall to expand and the diaphragm movement to normal, so that this creates more space in the thoracic cavity and allows the left behind lung to expand and help in oxygenation. But surgery has its own morbidity, like anesthesia complications. These are patients with high risk for surgery. Anesthesia complications, prolonged air leak, prolonged ICD, and these are the major complications following bullectomy. Coming to the second major surgery is lung volume reduction surgery. So here, the surgical resection of the diseased lung is being done. It is not lobectomy, it is part of the lung. But most of the studies mentioned that the predominant emphysema in the upper lobes has good results comparing to other lobes. So these are patients should be clearly selected for surgery. Here the problem is it is a high mortality surgery which has a mortality rate of about 8 to 15%. And most of the time these procedures are done bilaterally. So patient may require surgeries on both sides. So a open thoracotomy in these patients are not produces more morbidity. So these can be done through VATS or through robotics. So advantages of these lung volume reduction surgeries are they increases the elastic recoiling, improves the size mismatch of improves the size mismatch of the chest and hyperinflated lung, improving the expiratory airflow. It also improves the function of diaphragm and chest wall. So finally, this surgery is going to increase the quality of life by improving the oxygenation, FEV1, and exercise tolerance of the patient. And most of the time, this surgery is also done as a bridge to transplant, because most of the patients are in waiting list for lung transplant, and they are not able to get a lung. So to make them till they receive a lung, these procedures can be done. Coming to the last major surgery is the lung transplant. So this is done as a last option. So nowadays, most of the lung transplants worldwide are for COPD patients. So 40% of the transplant worldwide are done. Lung transplants are done for COPD patients. And the commonest age group are between 50 and 65. So this is a donor lung harvested after an surgery. So I am happy to hold this lung during my training program in Toronto General Hospital during my transplant program. And during that 1.5 months of training, they are done about 30 lung transplants. And most of them are bilateral lung. And they choose single lung only for idiopathic pulmonary fibrosis. So what are the indications for lung transplant in an COPD patient? So a post-bronchodilator, FEV1 less than 25%, or a resting hypoxia less than 55%, with associated hypercapnia and a life-threatening exacerbation. And there are many other contraindications which should be taken in mind before choosing a patient for transplant. So this is a photo after a bilateral lung transplant. Both the lungs are well placed and well functioning. And so coming to the prognosis of lung transplant, it is a high mortality and morbidity procedure. A 30 days mortality of 5 to 15% has been reported. But coming to the survival rate, a 5-year survival of double lung transplant is about 65%, and for single lung transplant, it is 45%. And for COPD, it is better survival comparing to other diseases. So to conclude, selection of patient for each surgery is very important. So you have to select your patient correctly. Surely these surgeries are going to improve the quality of life, but survival benefit are yet to be proven. Lung transplant remains the only option available for many patients with end-stage COPD. So in NIMS, we are completed our lung transplant inspection by the government, and we are waiting for the license to be, and we are waiting for few patients to listed in the KNOS transplant listing. So we are waiting for the first lung transplant to be done. So thank you for your support. Thank you very much.
Thank you, Dr. Asher. It's very nice. I was also in Toronto General Hospital for some time.
Thank you.
At that time, they were not doing lung transplant.
Okay.
Okay, Dr. Joshi is ready.
Yeah. Hello?
Yes, sir.
Is it audible?
Yes,
Yes, very much audible.
Okay.
Right, please.
Thank you.
Sir, Joshi sir, I will be sharing your screen now, sir.
Okay. You can put the first slide.
Is it visible now?
Yes.
Yeah. See, I am very much thankful to the organizers for giving me the opportunity to talk first. But unfortunately, with the technicality problem, I am almost to the last. So, my topic is what is new in gold guideline 2020. Fortunately, the 2021 guideline already in the market, but I have not got any time to go through it. So I am giving you the old
2020.
see So without wasting any time, I'll be going straight away to the topic. See, first we have to see the definition. See, in definition, there is, they have updated chronic obstructive pulmonary disease is a heterogeneous disease syndrome that is characterized by persistent respiratory symptom and airflow limitation that is due to airway and or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases and influenced by host factors, including abnormal lung development. Significant comorbidities may have an impact on morbidity and mortality. So in this situation, I'll give only the changes which is required. So the next slide. See, this is the algorithm. Once you have made the diagnosis by symptom risk factors and spirometry of COPD, you can do the initial assessment as per the GOLD guideline to give the treatment. So symptom is by CAT or MMRC scale, exacerbation history, smoking status, alpha-1 antitrypsin, comorbidities, then start the initial management. Of this non-pharmacological, it is very important is smoking cessation. Then you can vaccinate, active lifestyle and exercise, initial pharmacotherapy, self-management, education, because these are all in initial management guidelines. Risk factors management, inhaler technique, breathlessness, written action plan, and manage comorbidities. So after a period of 2 to 3 months, you can review the case with symptoms, exacerbation, smoking status, exposure, everything. Then, according to the symptom persisting, you can adjust the therapy. Next slide. Next slide is the etiology, pathology, pathobiology, and all these things. I am not going to the detail. And this is the pathway to the diagnosis of COPD. So you got the symptoms and you do the chronic cough and sputum, everything. Then risk factors are assessed and you do the spirometry and you can make the diagnosis. Next. See, this is the spirometry reading. And you can see that this is the normal for a normal adult. See how the peak comes at the 40 age, then it starts declining. That is the normal. But in COPD patient, once they develop COPD, there is a rapid decline. By 70, it will be very much lower. See, the lower line is when there is a small lung, the lung volume is less, and no COPD, it goes in the upper level, and when COPD develops, it goes down. So that is the normal characteristics of a normal person and a COPD patient in spirometry. Next. In differential diagnosis, one important thing is that some patients with chronic asthma, a clear distinction from COPD is difficult using current imaging and physiological testing. Physiological testing technique, since the two conditions share common traits and clinical expressions. Most other potential differential diagnoses are easier to distinguish from COPD. So the terminology of asthma COPD overlap syndrome is now removed. So that is a main change. And this is the differential diagnosis. I think everybody knows. COPD is differentiated from asthma, congestive cardiac failure, bronchiectasis, tuberculosis, obliterative bronchiolitis, and diffuse bronchiolitis. Next slide. This is the modified MRC dyspnea scale that every PG must be familiar, because this is always required, especially when you are managing COPD patients and even asthma patients. And these are the other causes of chronic cough. Apart from COPD, asthma, lung cancer, tuberculosis, bronchiectasis, left heart failure, interstitial lung disease, cystic fibrosis, and idiopathic cough. And even extrathoracic conditions are there: chronic allergic rhinitis, postnasal drift syndrome, upper airway cough syndrome, gastroesophageal reflux, and medication. Example is ACE inhibitors. Next slide. Key indicators for considering a diagnosis of COPD. So that is a description. Dyspnea that is progressive over time. It is a slow progression. Characteristically, but with exercise persistent, and it is persistent. The chronic cough is there, and chronic sputum production. Recurrent lower respiratory tract infection. History of risk factors are also you can get, and family history of COPD and our childhood factors that also contribute to the diagnosis of COPD. Once the COPD diagnosed, you can assess the patient by whether it is a 0 to 1 moderate exacerbation. So in that case, MMRC scale 0 to 1, or CAT score is less than 10, then it is group A. And you can give simple A bronchodilator. When the MMRC scale is more than 2 and category CAT scale is more than 10, you have to add a long-acting bronchodilator, either a LABA or a LAMA. And in C group, there will be 2 moderate exacerbations or more than 1 leading to hospitalization. So in that case, you can try LAMA. If that is not sufficient, then the patient is changed to group D, and in that case, LAMA and LABA or ICS can be added. So ICS can be added considering the high symptomatics and consider the eosinophil count. When the eosinophil count is more than 300, it is you have to switch on to steroids. If the response initial treatment is appropriate, maintain it. If not, you can consider changing the medication score in exacerbation. And this is the algorithm. And in that case, roflumilast is also can be added. And in former smokers, azithromycin is given if there is any persistent infection is there. And factors to consider when initiating ICS treatment in combination with 1 or 2 long-acting bronchodilators. Note the scenario is different when considering ICS. This is the strong support. History of hospitalization for exacerbations. More than 2 moderate exacerbations of COPD per year. Blood eosinophil count is more than 300 cells. And history of or concomitant asthma. Then consider the use of 1 moderate exacerbation of COPD per year or blood eosinophilia is in between 100 and 300. And a strong against is repeated pneumonia events. In that case, it is better to avoid steroids. Blood eosinophils less than 100 and history of mycobacterial infection because there is a chance of aggravating the infection. If a response to initial treatment is appropriate, maintain it and offer the management according to these. Contact information in the event of an exacerbation because he might have conducted an infection. When there is clinical suspicion of the following acute condition, you consider pneumonia, then you do a chest radiograph, assessment of C-reactive protein, and procalcitonin. Pneumothorax, chest radiograph or ultrasound. Pleural effusion, ultrasound or chest radiograph. Pulmonary embolism, D-dimer, Doppler sonograph of lower extremities, chest tomography, pulmonary embolism protocol. Pulmonary edema due to cardiac-related conditions, electrocardiogram and cardiac ultrasound. Cardiac anesthesias, cardiac arrhythmias, atrial fibrillation, flutter, electrocardiogram. Changes in the treatment The treatment has been discussed in various aspects. Here, the main changes has been in the Vedils and the section, because various studies have shown that there is no difference compared with the placebo in the number of COPD exacerbation over a 1 year period. So, adding of low dose theophylline to ICS in COPD patients is at increased risk of exacerbation. Combination bronchodilator therapy section. A large observational pharmacoepidemiological study found similar effectiveness of LABA and ICS LABA, but a significantly higher risk of pneumonia in those treated with ICS LABA for a longer duration. When the blood eosinophil count is less than 100 and more than 300, should be regarded as estimates rather than precise cutoff values that can predict different probabilities of treatment benefit. Triple inhaled therapy section. The change is that the search for a mortality benefit with inhaled respiratory medications in patients with COPD has been elusive. Prior large prospective and randomized trials with the mortality as the primary endpoint failed to show a statistically significant survival benefit with salmeterol fluticasone propionate or vilanderol fluticasone furoate compared to the monocomponents and placebo. Recently, trials utilizing triple combination of LABA ICS in comparison with LABA or LABA ICS have reported reduced mortality with the triple therapy. So, triple therapy is advocated in this. The other drugs with anti-inflammatory potential section. More recently, 4 large phase 3 studies have investigated the efficacy of the anti-IL-5 monoclonal antibody mepolizumab and the anti-IL-5 receptor antibody benralizumab in patients with severe COPD, recurrent exacerbations or peripheral blood evidence, eosinophilic inflammation, despite high intensity inhaled therapy. The study showed a 15 to 20% reduction in the rate of severe exacerbation, but the effect was not always statistically significant, and it was variable between studies and doses. So you have to assess with the individual patients. There was no effect on FEV1 or quality of life scores, and no consistent relationship between the response to treatment and the peripheral blood eosinophil count. A post-hoc analysis of the mepolizumab trial showed a greater benefit and more clear evidence of the blood eosinophil-related treatments effect against oral corticosteroid treated exacerbation, raising the possibility that this treatment might find a role in a highly selected subgroup of patients with eosinophilic COPD and frequent requirement for oral corticosteroids. Further studies are required to investigate this possibility. Then, in the smoking anti-cessation campaign, at the end, if the patient feels that he wants the feeling of smoking, e-cigarettes were originally advocated and promoted, and it was found that it produced severe acute lung injury, eosinophilic pneumonia, alveolar hemorrhage, respiratory bronchiolitis, and other forms of lung abnormalities, and hence it is stopped. Now, e-cigarettes are banned in India and several other countries also, but it is available still in Dubai, and people from coming from Dubai will bring and give to their friends and relatives the e-cigarette. That is the problem. In pulmonary rehabilitation, supervised exercise training at least twice weekly is recommended, and this can include any regimen from endurance training, interval training, resistance, strength training. Upper and lower limb ideally should be included, as well as walking exercise. Next slide. Pulmonary rehabilitation section. Supervised this is over. In all cases, the rehabilitation intervention should be individualized to maximize personal functional gains. when the intervention includes ongoing feedback, but without supervision. Change in physical activity is similar to a walking program without feedback. The importance of behavior change to facilitate physical functionality and reduce the physiological, psychological impact of COPD should be emphasized to the patient. Pulmonary rehabilitation is conducted at a range of sites. However, in real life, traditional pulmonary rehabilitation with supervision remains the standard of care and first-line option. There is insufficient evidence with conflicting research findings in the 11 available RCTs to recommend continuation of lower intensity or lower frequency exercise programs with the aim of maintaining benefits long term. Next slide. Education and self-management. There remain problems with heterogeneity among interventions, consistency of their application, specifics of the intervention, patient population, follow-up times, and outcome measures that make generalization difficult in real life. So it is a challenge. You have to. Next slide. For example, the definition, it is mentioned that the process requires iterative interactions between patients and healthcare professionals who are competent in delivering self-managed interventions. Furthermore, this randomized study indicated that health coaching delivered by a respiratory therapist or nurse may improve self-management abilities as demonstrated by meaningful improvement in chronic respiratory disease. Next, supportive palliative and end-of-life hospice care section. Nutritional support. Low BMI and particularly low fat-free mass is associated with worse outcomes in people with COPD. In malnourished patients with COPD, nutritional supplementation promotes significant weight gain and leads to significant improvement in respiratory muscle strength and overall health-related quality of life. A 12-month nutritional intervention in muscle-wasted patients had no effect on physical capacity, but physical activity was insignificantly higher. Vitamin C, E, zinc, and selenium has been shown to improve antioxidant deficiencies and cordyceps strength. And serum total protein without further improvement in cordyceps intervals. Only in malnourished patients has nutritional supplementation demonstrated significant improvement for 6-minute walk test. This I can't, I think this can. Next slide. Bronchoscopic interventions to reduce hyperinflation. A large multi-center prospective RCT of endobronchial valve replacement in patients with heterogeneous emphysema distribution and little to no collateral ventilation demonstrated significant clinically meaningful benefits over current standard care in lung function, dyspnea, exercise capacity, and quality of life out to at least 12 months post-CDR. Pneumothorax was seen in 26% of subjects, 26.6% of subjects treated with the endobronchial while within 72 hours. Another large multi-center prospective RCT using different type of endobronchial valve in patients selected for targeted lobe treatment based on Fisher integrity assessment by high resolution chest CT showed a significant between group increase in mean FEV1 from baseline. Next slide. In conclusion, in 2020 GOLD guidelines has consolidated previous recommendations on the diagnosis, assessment of COPD in its initial and subsequent pharmacological and non-pharmacological management. It gives more stress on patient education and physical training. It advocates a more comprehensive and holistic approach. Thank you very much.
Joshi. Thank you, Dr. Joshi, for being a sport, because your talk was shifted to last, but you have done very well. Thank you very much.
Thank you.
Dr. Ghosh,
Yes, sir.
ready?
Ready.
ഇത് മാറ്റി കൊടുക്കും.
Yes, sir.
അല്ല
Now
ഇത്
it's-
ഘോഷ് എഴുതി ഞാൻ കേട്ടോ.
Screen is visible.
Visible.
Yes, sir.
Coming up.
Yes, it's coming up, sir. You have to open your PowerPoint.
Yeah.
So please press launch meeting.
Yes. Pressing.
Yeah, launch meeting. Just press that, sir. Launch meeting. Launch meeting. Yes. Just press it, sir.
Yes.
And now press join from your browser. So now there is join from yeah.
Sir,
Join from browser.
Sir,
So
minimize.
down,
Sir,
join.
minimize the screen, sir. There is a minimize the screen. Yeah. PowerPoint. Now we can see your desktop. Open the PowerPoint. Yes, sir. Just double click on this. Yeah.
Yes, it's coming up.
So, can you see it?
Yes, sir. We can see the slides.
Yes, sir, we can see. We can see.
Thank you. Thank you. Okay.
Yes, sir.
Okay, fine.
So, first of all, let me thank Professor Ravindran for giving an opportunity to introduce the economic data with reference to COPD exacerbation. So, we will be discussing the source of the data, outcome in COPD with relation to the economic burden, and need for understanding cost as well as the effectiveness. The definition of COPD has already been dealt with by many speakers, especially Dr. Ravindran. And the severity, and it's important because the healthcare utilization is directly related to the severity of the COPD exacerbation. And you can see that it's severe rapid deterioration condition may require hospitalization, which is directly related with the health resource utilization. Healthcare cost and resource use, healthcare cost perspective of the, usually it is assessed with the National Health Service perspectives, and cost is usually quantified using charges, that is the amount of money the health system reimburses to the provider of care. Healthcare resources were divided into mainly three groups, at the hospitalization cost, prescription drug cost, and outpatient claims. As you can see, the major data for analysis usually comes from the epidemiological studies, which include cross-sectional study, cohort, case control, randomized control trials, and meta-analysis. And the economic variables are usually in relation to cost of illness studies, cost minimization studies, cost effectiveness studies, cost benefit studies, and cost utility studies. As you can see, we have already discussed the management of exacerbation, whether it is bacterial or viral. But you know, in addition to pharmacological intervention, where you are using antibiotic or antiviral, a COPD exacerbation, depending upon the severity of the disease, may require non-pharmacological resource use. As you can see that oxygen is very important, and costing of the oxygen requirement is very important. Then the non-invasive ventilation and invasive ventilation, NIV, high flow nasal cannula. Some institutions where ECMO is available, some patient may require it. And most of the patient, as Professor Joshi said, pulmonary rehabilitation is important. Palliative care is also involved resources. Then general measures like quit smoking, vaccination, nutrition, that has already been discussed. Dr. Ashar said the importance of lung transplantation. So these are the resources. that may recur, because we want to prolong the life of the patient as well as improve the quality of life of the patient. So two objectives that should be achieved, but the amount of resource that is involved depends upon the severity of the condition. And you can see, we can predict the probability of a mortality in a COPD patient by taking some of the important clinical parameters like FEV1, distance walked in 6 minutes, MMRC, dyspnea scale, and body mass index. And combined, you can calculate the body index. For example, if the body index score is 0 to 2, there is 2% mortality in 1 year, 90% mortality after 4.5 years. And if it is 7 to 10 at the start, you may see that the first year mortality is 5%, but the 4.5 years mortality is 80%. So, in Canada, at Alberta, the COPD economic surveillance was done by the Institute of Health Economics. They found that the population at risk of COPD, they spend more than $24 million for 539,000 smokers. You can see onset of the COPD, and once the COPD is diagnosed, they have 88,000 diagnosed cases, and they calculated an expenditure of $16 million. At the lower level of severity, they found that there are 49,000 participants, and they spent 27 million. An interesting fact is that the last, where the higher severity score, the number is small, but the amount of money that is spent on managing such cases is 187 million. And this area shows the distribution of the economic burden with reference to COPD exacerbation management. You can see that the number of people who are managed with the prevention using vaccination is very, very low in a developed country like Canada. And when coming to India, you can see the economic studies with the reference to COPD and exacerbation in India is very, very limited. And you can see that the initial study done by KGR Murthy et al. Found that India, there is a loss of 45,000 crores as a result of COPD related comorbidities and exacerbation. And he also stressed the fact that if we can manage COPD in the optimal way, we will be able to save 40,000 crores. So that was an eye-opening study with reference to COPD in India. And here we are relating the economic benefit in relation to the outcome of management. You know, in a chronic disease like COPD, the most important clinical outcome that we have to measure is the quality adjusted life years. So here it is, we are trying to relate the cost with the quality adjusted life year gain. You can see that telehealth, which is being recommended in many situations and mainly done in many of the developed countries, they found that for each quality adjusted life year, the amount of money spent in UK is £92,000. And if you consider triple drug therapy for each quality adjusted life year, they spend around £7,000. When you are using LABA for improving quality adjusted life year, then the amount of money that is invested is the £8,000. When you are using tiotropium, they found that for each quality adjusted life year, you are spending around £7,000. If you are using pulmonary rehabilitation for supporting patient with repeated or recurrent exacerbation, you see that only 2,000 to 8,000 pounds for each quality adjusted life year. And if you implement successfully smoking cessation, you find that it is one of the most cost-effective way of improving the quality adjusted life year of a COPD patient. And flu vaccination, that is also found to be a very cost-effective method of improving quality adjusted life years of people with this COPD by preventing the exacerbation. People have done many appraisal in the literature with the available articles. Here you can see Ike et al. Have done an economic burden of chronic obstructive pulmonary disease, a systematic literature review. He could retrieve only 73 primary publications, 63 only reported health resource utilization, and 22 reported direct cost, and 1 reported indirect cost. And most of the studies, that is 94% of the reported studies are from data from Europe and North America. They found that higher costs are associated with severe COPD and a history of more frequent or severe exacerbation. A multivariate analysis which was done in 29 studies that they have evaluated also supported this statistical conclusion. And you can see these are the countries from there where they collected the data with reference to COPD to assess the economic burden. And you can see that direct cost was measured only in 22 studies, indirect cost only 1 study, health resource utilization was reported in 66 studies, and a multivariate analysis with reference to the significance was assessed only 29 studies. Study done by Theophilus in 2018, which was showed a cross-sectional study at a teaching hospital in South India, and this was reported in the Journal of Family Medicine and Primary Care. They found that the risk factors for exacerbation in COPD with reference to our country is related to increasing age, severity of the FEV1 impairment, mucus hypersecretion, frequent past exacerbation, daily cough and wheeze with reference to chronic bronchitis, and association of comorbid conditions like mainly cardiovascular disease. They estimated in their article the mean total direct medical cost with reference to management of a COPD exacerbation is around 80,000, that is 29,885, and the mean total direct non-medical cost was estimated to be rupees 7,441. And they found that there is a significant difference between patients with COPD developing exacerbation having comorbid condition compared to those without comorbid condition. And they say 28,148 versus 18,340. The major drivers of total cost were hospitalization and medication cost. And as you can see, they measured the quality of life by using the St. George Respiratory Questionnaire. They found that the symptoms and the activity scale is better for a person with 0 to 2 exacerbation per year when compared to more than 2 exacerbation per year. Another important study is the COMET study, where the cost effectiveness was evaluated in 390 intention to treat patients over 12 months. And their analysis captured unplanned all-cause hospitalization days, mortality, and quality adjusted life expectancy in COPD patients. And costs were evaluated from the National Health Service perspective for France, Germany, Spain, and quality of life assessed using 15D health-related quality of life instrument as well as mapped to utility scores. They found that the home-based disease management strategy was associated with improved life expectancy. They said that disease management strategy reduced the direct cost by euro 37 per patient per year. And disease management strategy was associated with 80.6 euro per patient per year in France, 51 euro per patient per year in Spain, and it was 391 euro per patient per year in Germany. And evaluation of cost for death avoided and cost per quality adjusted life year gain was also estimated, and disease management was dominant. That is, more qualities are gained with less amount of money in France and Spain. And they also documented that disease management strategy was cost effective in Germany, where estimated the incremental cost effective ratio for euro 2,541 per quality of life, quality adjusted life year in Germany. Here you can see the number of coexisting comorbidity conditions in COPD patients and its control. You can see that a significant number of patients have at least one comorbidity, then 2 comorbidity, 3, and there are many patients in their study who had 4 comorbidities, which may definitely impact on the economic burden related to management of COPD. And the mortality among cases and 16 controls, among the cases and control, they reported that 43% was the mortality among COPD patients, as we can see, which includes sudden death, myocardial infarction, heart failure, other cardiovascular causes, respiratory failure, sepsis, cancer, and others. So mortality was 43% among COPD and 60%, 16% only controlled. A Kaplan-Meier survival curve in these 200 COPD patients were compared with the control, and they found that there is a rapid increase in the mortality as years goes by. You can see that by year end, there are large number of patients in the COPD group that died when compared to no COPD patients. So COPD is definitely impacting on the survival of patients, especially those who are having acute exacerbation. And they also documented that the number of survival percentile is very less for COPD patient, because it was only 4.56 for 4.5 years. By non-COPD patient, it extends to up to 10 years. Similarly, they also documented that the survival is significantly shorter among patients in lower tertile of FEV1 and DLCO than in all others, which was statistically significant. So that is another finding in this study. And this is the amount of euro that is spent as a direct cost, which include outpatient cost, inpatient cost, medication cost, rehabilitation, aids and remedies, travel cost, and total direct cost. This has been estimated for different levels of severity in COPD. And they also calculated the indirect cost with reference to sick days lost, premature retirement, and total direct cost was estimated to be 11,846 euro for the mild group, and it's 22,932 for the group 4 patients. Post outcome in COPD care, which has been estimated by the Anand et al., and which was reported in respiratory medicine, they calculated that the mean cost for emergency room visit was $647, for simple admission $7,242, for complex admissions $20,757, and intensive care with the intubation estimated 44,909, and complex admission accounted for around 5.8% of hospital admission. But when you estimate the cost, they have found that it covers more than 20% of the economic burden. And cost and length of stay in the emergency department in inpatient admissions, so you can see that emergency department visits, simple admission, complex admission, intubation, ICU plus intubation, all encounters, the cost was calculated for different grades of COPD, and it has been reported. So here you can find the amount of money that is spent with reference to patients who requires intubation, ICU without intubation, and ICU with intubation. You find that the amount of money that is spent for an average case is around $50,000 for that study. So which indicates that a huge amount of money is spent for managing patients who are having far advanced COPD. The study by Parvez in post of severe chronic obstructive pulmonary disease exacerbation in a high burden region in North India. So with reference to India, another study, they found that the median cost of hospitalization was 44,390 per admission. And the cost incurred to the hospital was highest, that is 71%. Cost directly borne by the patient, 29%. Cost of medication was 14%. Transportation charge was 2%. blood chemistries and imaging 3%. Indirect cost calculated as financial loss due to missed work days to caregivers, and that accounted for around 4% of the total cost. The median indirect cost they have calculated to be 1,544. The median cost of discharge medication was estimated to be 700. They also demonstrate the cost component with reference to each of the activities that is important for diagnosing and managing COPD, and they found that the total cost is around 44,390 in South India. This showed the incremental effectiveness of interventions, and you can find that vaccination is found to be one of the best intervention because it saves a lot of money. And this shows the impact of disease management program on COPD, a systematic review, and they found that most of the patient improves healthcare utilization with early intervention, and the hospitalization cost also comes down. So to summarize, exacerbation of chronic obstructive pulmonary disease determine disease-associated morbidity, mortality, resource burden, and healthcare cost. Acute exacerbation care requirement range from unscheduled primary care visit to emergency room, inpatient or intensive care, generating significant cost in COPD. Even after exacerbation resolves, respiratory, physical, social, emotional impairment may persist for prolonged time. Frequent exacerbation, mainly in patients with severe COPD, accelerate disease progression and mortality. These patients with the frequent exacerbations have a more rapid decline in lung function, worse quality of life, decreased exercise performance. And management of COPD directed to reduce incidence and severity of exacerbation, improves long-term health status and conserves resources. Thank you.
Thank you, Dr. Ghosh, for an exhaustive the economic loss in COPD, the economic burden to the nation, and also probably to the nation, the state and the nation by COPD. I think we have come to the last part of it, and no further speakers. So my duty is to find out this one. Is, I hope everybody can hear.
Yes.
Yes, sir.
Yes, sir.
Yes, sir.
And here what I am going to say. But,
Yes, sir.
right now, I am sure that you have all realized that COPD is a huge topic. It is not possible to cover all areas in 1 2-hour session. It has to be done in a half-a-day session or a full-day session, or you can restrict to 2 or 3 lectures for COPD. The most important lectures which we decided by the organizers. If you are doing like this, that means I think so many may have dropped out and may not be available now to listen to the last part of the program. Anyhow, everybody has done very well, and all the participants have given all their attention and all their effort to give a good talk, and that means all the PGs and young budding pulmonary physicians would have had a good exposure to various stalwarts in the field of pulmonary medicine from most of the parts of Kerala, including way back from Calicut. So I do not want to tell anything more about it. Most of the points have been discussed, and some points require more attention, but time is very late. So I will sum up this meeting as a wonderful day on which COPD has been really discussed. The most important thing is COPD, this thing, the COPD, the Gold has said that we have to, every patient should get a written statement of what they have to do during a acute exacerbation. Every patient should be given a idea of how to keep themselves active, and patients should receive vaccinations, and they should also be given, not only that they should know what is allowed to be active in their life throughout, without keeping quiet, to go undergo training, physical training, and that proper diet, which has to be high protein diet, has to be supplied to them. Those are the things WHO, the Gold has said for this year's update on COPD. With this few words, I end up this session. My thanks are due to Dr. Preeti, Dr. Manu, and Dr. Kamala for inviting me to chair this session. Thank you all.
Yeah. Thank you, Honorable Chairperson. You conducted the meeting so well, in spite of our shortcomings, actually. Thank you so much. It was such an interesting session. Happy birthday to Dr. Ravindran C. Thank you very much, Dr. Joshi sir and Dr. Ghosh sir, Dr. Anita madam and Dr. Jayaprakash sir, and Dr. M.R. Nair sir and Asha Nayagam. So thanks all of you. It was such a wonderful session, Dr. Madhu. It was so kind of you to help all of us, and you and Dr. Ajoy also, to help us all conduct the meeting. And the lectures were really wonderful and very exhaustive. Thank you, TAPCCM and all its members for being tolerant to us. Maybe we had a lot of shortcomings, but we tried to conduct it for the World COPD Day. Thank you. Madhu, do you have anything to say, Madhu? And thank you, Lupin, of course, for giving us this web platform. This is Mayur, the marketing team.
Thank you very much, Preeti ma'am, and especially thank you, Chairman Dr. P. Ravindran and entire all members of the Trivandrum Society. And I really appreciate you took out the valuable time from your busy schedule. I can understand that being a chest physician, it was really difficult for you to take out the time, because looking at the current scenario of the pandemic, and still you people managed to do it, and we really appreciate that. So on behalf of entire Lupin Respira division, I thank you all the faculty members and entire audience who listened to all of us patiently and participated actively. Thank you very much, every one of you.
Thank you.
Thank you.
Thank you, Ravindra sir, for joining us.
Yeah, thank you, Dr. Madhu. Thanks a lot for helping us. Thank you very much. Thanks.
Thank you, sir.
Goodbye.
Bye.
Thank you, Dr. Ravindran sir. Thank you for coming from Wayanad all the way. Thank you.
Ravindra sir, happy birthday. Thank you very much.
Birthday.
Very interesting to be a part of this group. Thank you.
Thank you, Ravi, for joining us. We will invite you many other occasion also.
Ajay, thank you for conducting the meeting excellently.
Okay.
Well coordinated.
Thank you, sir. Thank you, sir.
Thank you, Ajoy. Thanks.
Let's hope for a real meeting very soon.
We hope so.
Yes.
We pray for that.
Yeah.